let's moving for the next session. Really thanks. And first of all, you have a technology question for Bill Trattler. Please, the question here. What technology are you looking for to the most in the post-COVID era and why? Please, Bill.
Hi, I'm Bill Trattler from Miami, Florida. And this has been a very challenging time for all of us. But thankfully, we're starting to see some improvements. We're seeing more patients come back to our practice to see us for regular exams, and we're starting to see surgery volume increase. So things are moving in the right direction. The technology I'm most excited about is a technology called the light adjustable lens. Now that we're starting to see more patients and doing more surgery, this is a technology that I think is going to be a major part of my practice going forward. I had a chance to work with this technology just prior to COVID-19 hitting, and my results so far have been quite promising. I've been able to take patients who've had previous refractive surgery or other issues with their eyes, and then after surgery, make adjustments with the light adjustable lens, and they've all done beautifully. They've had wonderful visual outcomes. So I think this technology is very promising. I think our ability to end up on target has improved over the years, but the light adjustable lens allows us to really end up with really fantastic visual acuity and visual results. So far my patients have been extremely happy. As a surgeon, I've been very happy, and I think this is a technology that we can all be excited about. Thank you.
And Bill, I don't know if you saw the session yesterday, but my question was, when you invite us to Miami, guy? Okay, but before to start the session, please the ASCIS. Okay, guys, you have associate to ASCIS, and everybody, Terry and David send it for us, and everybody who was here in the WWCIS webinar have a 50% in discount in all ASCIS virtual meeting. You need to only go to ASCIS website and you have the discount. It's a pleasure for us, for me and for Ash, to be associated to ASCIS and help in this ASCIS virtual meeting. And now the polling question first.
On the WWCRS website, the World Webinar website.
Yes. Thanks, boss. And the polling question about refractive surgery. In a patient aged 36 years of age, means the last 10 degree power and good keratomet map, I prefer to perform. You can choose. You have 15 seconds. And while the audience do answer the question, Marcony is a great friend. Thanks to accept our invitation. Andres, Wolfgang, Roger, Argentina man. Sorry, but Brazil. And Sharma and William, thank you. And the answer is Phakic IOL. Okay. Let's move on. Show the video, and the stage is yours.
Refractive surgery session. The coordinators: Marcony, Santhiago, and William Trattler. Guest panelist: Andres Benatti, Argentina. Featuring speakers: William Wiley, USA. Wolfgang Rhia, Austria. Namrata Sharma, India. And Roger Zaldivar, Argentina. Organizers: Sergio Canabrava, Brazil, and Ashwin Agarwal, India.
So welcome to the refractive surgery session, and we're so excited that all of you are attending. I know it's a huge international crowd. I know yesterday's attendance for day one was tremendous, and I know we're all excited to be here. As you know, we have Marcony and I are going to be the co-moderators. We're excited to have Andres Benatti to be a panelist. And then the talks today are just going to be fantastic. And I think what I hope everyone understands is that refractive surgery is such an important part of of ophthalmology and taking care of patients. Whether patients in their 20s or patients in their 70s and 80s, having people see well, at any time point in their lives is so critical. And so I'll make this intro short. We'll go right to our first speaker, which will be Wolfgang Rhia. I'm super excited for his talk. And it's going to be on advances in corneal refractive surgery and complication management.
So, Bill, thanks so much for the introduction. I hope you hear me well. First of all, it's a really pleasure to be here today, and I want to thank Sergio and Ashwin for the opportunity. It's great to have great education and see the family in the same weekend. We're not used to that so far. So I wanted to talk today about something that's getting close to be used, really. There are many fascinating projects out there. The allograft inlays, the lyric we heard from Arthur Cummings yesterday will be on the horizon. But what's really being able to be used soon? So we are very fortunate. As young refractive surgeons, we got all this great technology from our predecessors, from the pioneers, from the companies. We basically can treat so many patients right now. We get amazing results. We can choose which color we want, but if you do phakic IOLs, if you do SMILE, if you do LASIK, you basically get great results. So what should be our common goal? And I think it's about really bringing the benefits of refractive surgery to as many people as possible. What about maximizing results, minimizing complications, and keep it simple and stupid for the user, because that's how you make the numbers. And I think that's really so important. And as Bill said, vision will drop in the future. So to make most out of the optical system is really important. So talking about laser vision correction, these days, it's a lot about individualization. So find the right technique for the right patient and then customize this treatment as much as possible. For me, the next step in customized laser vision correction is truly optical ray tracing. And this is a paper published years ago by Michael Rockley and Theo Seiler, one of the pioneers in this field. So this is not something new, but now it's really, there's a lot of work that got into it, especially from the Wavelight lab in Erlangen by Alcon, and lots of scientists and lots of also colleagues that put lots of effort into that. It would exceed 5 minutes to mention them all. So just a few words about the basics. You might know the Gauss-Strand eye model is the model that has won the Nobel Prize more than 100 years ago, and now it's still the basis. It defines the basis of lots of most of the ablation profiles we're doing right now. So not only the standard profiles, but also the optimized profiles, wavefront guided, topography guided. So this is based on calculations more than 100 years old. So what does now ray tracing doing right now? As I said, the most treatments we're doing are standard. We treat manifest refractions and theoretical assumptions, and still topo guided, wavefront guided are using those theoretical assumptions. So what does ray tracing now do? It's a custom treatment, and they try to get the assumptions and the formulas out of this and just use the real data. And I think that's why it's so important. It's basically a two-step technology. The one is a preoperative technology made it's a device by Oculus. It's called Innovice Sitemap. It basically, you get all the information you need. You get topography, tomography, Hartmann check, aberrometry, as well as biometry. So what the software, the algorithm does, it builds basically a three-dimensional avatar, a model of the eye to be treated. So it's about lens position, it's about the actual lens, and it's an iterative process going back and forward, trying to find the best way, the best possible ablation profile to treat the errors of this special eye on the corneal plane. So that's an algorithm, and when we started this years ago, it basically took 6 hours of calculating for one treatment. So now this is done within a few seconds, and thanks for all the progression and computer performance, etc. So what it does, it uses basically all Zernike polynomials, low order, high order aberrations, as well as tilt, which means that the different planes of the cornea and the lens. And it's getting quite easy. You get all the information of the treatment, of the measurement, as well as the treatment afterwards. So we're talking about, that's data, that's real data, that's no assumptions. And I think that's why it's so important and makes it quite easy. Obviously, the quality of the measurements are key, but that's nothing new in refractive surgery. It can take a while. It can take up to 20 minutes on this one machine. And you need circumstances like a 5.5 millimeter pupil for the wavefront aberrometry, and then you get a good result. If you don't get that, and there are patients where you don't get good measurements, you still have to do the other treatment profiles we can do. But if you can do it, it's a really step forward. Obviously, cyclotorsion control as well. So let's see some clinical results, and they're quite impressive. Already published a while ago. There are more studies on the way right now we are involved in as well. So 70% of the eyes achieve a same or better uncorrected acuity than the best corrected acuity before surgery. If you compare how many lines, taking the refraction out of the game, just the corrected distance visual acuity, 50% of the eyes gain one line or more. That's quite impressive as well, and better than the other treatment profiles we're using right now. The treatment range for now is myopia and myopic astigmatism, optical zone 6 to 7 millimeters. What's also new is that we get a larger transition zone now than what we used before. The predictability was shown as to be quite good as well. Again, there are lots of studies on the way right now, more publications that will come up. And to stay within the 5 minutes, I try hard. I think, most or probably all platforms and profiles today we're using are safe and effective to use. So use it. What does ray tracing offers you additionally? It's measuring and treating the first time the complete optical system, getting rid of assumptions and formulas. This is also why you don't need nomograms. The quality of the measurement is really the key to success. There's a new spot distribution profile compared to optimized profiles. And for me, it's just one step further to full customization and to getting even better results. And I don't like I hate the term 20 happy. I want the best possible results that we can achieve, because down the road, years from now, vision will decrease in all patients. And when we start higher, when we start at 2012, there's more room for loss. And I want to end my lecture with a quote by a dear friend and one of the great leaders in ophthalmology right now, Roger Zaldivar, who will be the next speaker. Hi, Roger. And he's president of the RSA, and it's about bringing the benefits of refractive surgery to as many people as possible through collaboration. So guys, globally, let's work on that. Let's not fight each other, let's help each other, try to make most of our technology and the best for our patients. Thank you so much.
Wolfgang, that was fantastic. I'm sure the panelists and the other speakers may have some questions. I have two questions for you. The first is, would this technology also work for PRK? I know the study what you did was with LASIK. Would you expect similar results with PRK?
Yes, absolutely.
Okay, and the second question is, I noticed that the study was up to -11. So the question we had a moment ago to start this off was treatment of a patient who had 10 diopters of myopia. So in your hands, 10 diopters of myopia, with this technology, will this surpass a phakic intraocular lens, or would you still at -10 go with phakic intraocular lens?
I think with the -10, it's, I love phakic IOLs. I think it's a great thing, and I'm truly a fan, and we use it a lot. And with -10, I get great results with laser vision correction as well with -10. So it's hard to answer. We will see. But it's okay. Hard to put an ICL in a -10. That's for sure.
Perfect. Any other questions from the other speakers or panelists?
Yeah, well, do. First, I'd like to say hello to everyone. Since it's the first time I'm speaking, I'd like to say hi to you, Bill. It's fantastic to be here with you and with all the presenters today. And obviously, I'd like to thank you very much, my friends Ashwin and Sergio Canabrava. And you guys probably don't know something about Sergio. I have to reveal it right now. Sergio is a very nice guy. I love him, great friend, but he's a fan of the worst Brazilian soccer team ever. True. He has to tell you guys this. I mean, I'm so sad for him, but I have to reveal this truth right now. Anyway, moving forward, he can elaborate on that. He can elaborate on that later. And I'm also, before I move forward, I just want to ask Rhia a quick question. Do you know the difference? First, congratulations for this very good presentation. But do you know the difference in terms of maximum ablation depth between the ray tracing guided treatments and the wavefront and optimized and topo guided treatments? Is that a huge difference between them, or not significant?
Yeah, I see in those treatments a little bit of you need a larger amount of tissue to treat them.
Mm-hmm.
in
because
general.
that is an important thing, especially for high myopic eyes. We may change our limits.
Yes.
Wolfgang,
sorry, I have a question. Sorry.
Go ahead.
First of all,
Andres Benatti is with us too as a panelist, and I'm also very happy that I have 2 Brazilian guys here and 2 guys from Argentina, because since I'm a Flamengo fan in Brazil, we beat an Argentinian team for the Libertadores, and you know the rivalry, right, Bill? You know that, so
you can
right,
easily.
Andres.
It's
Go
easy
ahead.
to realize. It's easy to realize who are the Argentinians because we are the only 2 that don't have background. So always breaking rules.
That's true. That's true. So first of all, thank you, Marcony and William, for having me here. It's a big honor, and of course, Ashvin and Sergio, congratulations for this amazing event. Wolfgang, I have just one quick question. Do you have any experience with Forcides, the software to improve the results with topographic guided surgery?
No.
No. Okay. What do you know, Marcony? Have you had any experience with Forcides?
No, I don't. I mean, just literature, but not that I have done myself.
Okay.
Yeah, my understanding is that it's my understanding is that the Forcides is just an upgraded method for calculating topo-guided treatments, and they're getting better visual outcomes. So my colleagues who are using it are very, very happy with that technology. So I've heard great things about it.
Yeah, I've had some experience, and Forcides is great. It's made topography guided easier, and it's one of the first tools to take into account the posterior cornea when looking at the topography guided treatments. As we know, most other treatments are just looking at anterior, but having the ability to look at the full thickness and looking at that posterior float, I think helps raise the accuracy. I was curious, Wolfgang, great talk, and I really like the ray tracing angle, and I think that can definitely help eliminate some of the outliers we see with refractive surgery, particularly on those higher prescriptions. I'm curious, does the software take into account any biomechanics of the cornea, let's say, or potential biomechanical effects of the cornea, or is it all optical?
I think it takes this into account. I'm not so much into the technical details, but
Sure.
what I've heard is it takes into account, yes.
Hello, can we move forward, Bill? All right, so moving forward, I'd like to invite our next speaker, who is Roger Zaldivar. Before you start to speak, Roger, I also would like to highlight the International Society of Refractive Surgery, that is doing a great job. Sergio and Ashvin are also members, and Bill too. And Renato Ambrosio is our current president. And we have a meeting that is going to be in Las Vegas this year. George Waring and Buka are doing a great job planning a great meeting. I hope the meeting is going to be in person, and that will be great. It's going to be between 14th and 16th of November. But if not in person, I'm sure it's going to be a great virtual meeting, if not in person. But hopefully it's going to be in person. So I just want to highlight that, because ISRS is also doing a great job, and I know Ashvin and Sergio are also involved too. Roger, you're going to speak for us about phakic IOL. You and your father have done a fantastic job, teaching us about phakic IOL. It's going to be a pleasure to hear you, my friend.
Thank you very much. Thank you for this kind introduction. And again, I want to echo yourself and congratulate the organizer, because this has been a tremendous experience. So just moving fast to my talk and to respect the time, I don't have any financial interest. And a lot has happened since the first ICL with central flow was inserted back in Argentina at the beginning of the 90s by my father. Today, just for you to have as a reference, there is an ICL inserted every 2 minutes in the world. It is by far the most dominant platform being used, with average 90% of the market share. And truly, a lot has been related with this central flow, since it has really improved the safety profile and has avoided most of the important complications like cataracts, taking that close to zero. Still, the main concern today is the sizing, mostly related with sizing methodology. And despite it's very, very forgiving platform, because in terms of distribution, it accepts most of the results. We have to be careful with the extremes, more related with the overvolting, since we know today that with the central flow, we have a much better behavior with undervolt. But what we really want to avoid is the possibility of having this kind of complication that, for example, this pupillary block. These are complications that can harm the eye, and we really want to avoid them. So in my talk, I'm going to focus on volt. So first of all, predictability. Two of the most used predictability formulas are from Japan, from Nakamura, and the other one is from Akihito. Both are based in OCT. And we compare our patients with these two formulas. And interestingly, we truly have a lot of scattering the results, as you can see here in the graph. And despite the average is acceptable, the standard deviation is truly unacceptable. So a couple of years ago, 2 years ago, we decided to move forward and acquire these two important platforms that I don't have any financial interest, by the way, and we are using them in a standard base. One is intraoperative OCT, and the other one is the ARCAN, that is high frequency UVM. So as you can see here, one of the interesting things is where the ICL is positioned, where are those fit. So here's one of the options that is in the ciliary body to ciliary body position. The other one that is not very infrequent is ciliary body to sulcus in an asymmetric kind of position. And the other one is sulcus at the sulcus to sulcus, where we all thought that this was the standard. If you see the results, you'll be pretty surprised, as we were a couple of years ago. And 83% of the cases go to the ciliary body. 13% of the cases go to the ciliary body to sulcus in an asymmetric way, and only 3.7% go to the sulcus to sulcus. This may explain a lot the lack of predictability. So first important conclusion, most of the traditional ICL formulas based in ultrasound rely in sulcus to sulcus measurements, and only 4% of the lenses are sitting there. So if we go to correlation coefficient, we have sulcus to ciliary body, we have an acceptable coefficient of 0.7. And if we go to angle, which is other of the factors that some people take into account, it has a 0.6 correlation related to ciliary body, and the worst correlation of all between is this white to white, which is only 0.3 related to angle, 0.2 to sulcus, and 0.29 to ciliary body. So it's very, very low correlation, almost no correlation. The other important thing that I want to mention in this quick talk is intraoperative OCT, and inspired by this paper done by Torbe, where he showed high correlation between immediately intraoperative OCT 1 day, 1 week, and 1 month, and 3 months. We started using this, and in 592 eyes, we had the mean intraoperative volt was 656 microns, compared to 1 day 625, where you see it's a really high correlation. And these are our numbers. So why is this important? Because if we're really thinking in avoiding this extreme complication of hypervolt, and based in the paper from our friends from Oviedo, the Fernandez Vega, we know that if we rotate the platform 90 degrees, we can truly decrease the size of the volt. And as you can see here, what we will see is just a rotation of the ICL. We didn't like the volt that we have acquired, so we decided to rotate it 90 degrees, and you will see in the difference immediately after the procedure how we measure. Look at this, we decreased 300 microns just rotating the ICL to a vertical position. I think this is very important. And in 592 eyes, we rotated 17 ICLs. This was last year. An average was 380 immediately, and 1 day around 400. But this is the average that you can decrease the volt by rotating to a vertical position. So as a conclusion, I think that the Aquaport was a great step forward because it truly facilitated the surgical technique. It improved the overall safety profile of the platform. Understanding where the ICL is hosted will now allow us to make a better predicting formula. Intraoperative OCT is a great aid to avoid extreme bolts and optimize them in the OR. And ciliary body to ciliary body measurement by the R-scan looks very promising in order to predict the bolt more accurately. Thank you very much.
Thank you, Roger. Roger, you always bring it, and that was just a spectacular talk. I know that's been my major issue is sizing. I was asked by Ashwin and Sergio, they want us to hold the questions and answers until after all the talks, because that way other people can write in. Please ask your questions on the chat, and then we'll answer them all afterwards. So with that, I'm going to introduce Namrata Sharma. We're very excited to have you speak on the importance of OCT of the cornea in refractive surgery.
Thank you, Dr. Trattler, and I would like to thank Ashwin and Sergio for having me here on this webinar. And I would be talking to you about intraoperative OCT device, how it can help in refractive surgery. And I have no financial interest or proprietary interest in the microscope. So how does IOCT help with the surgery? This is in cases of SMILE. So when you do SMILE, intrastromal lenticule is created using 500 kilohertz femtosecond. And then you can actually, with the MIOCT images, one can see the feedback images that tell you, they delineate the anterior part and the posterior part of the lenticule and help in subsequent dissection. So the incision can be opened and entry can be done anterior to the lenticule. And likewise, with the help of the dissector, one can go in the anterior lamellar plane and the dissection can be done and the tip can be visualized. So adhesion between the lenticule and the overlying stroma can be seen. And if there's any false plane which is there, that can be immediately checked and verified on the anterior segment OCT. Now, the plane posterior to the lenticule is also opened using the tip of the dissector. And as you open it, you can actually see that you are going posteriorly behind the lenticule and separating it from the underlying stroma. And then subsequently, one can take out the lenticule, which has now been dissected with the help of the microforceps and extracted in toto using lenticulorhexis technique under the MIOCT. So one can then inspect for the integrity of the lenticule, and if there are any remnants which remain inside, then one can also check inside the interface if there are any remnants which are present, and these can also be retrieved. Now, this is especially useful if you've done too much of needling and the cornea becomes edematous, especially for the surgeons who are in their learning curve and you can't make out where the retained lenticule is. This is post-op day 1, and this is something that we published, management of cap lenticule adhesion during SMILE using IOCT, and then subsequently how IOCT can help in SMILE, a new surgical technique. I think Dr. Zaldivar talked about this, and then again we can do IOCT guided ICL. So these incisions, although the OCT is not being focused, but you can see the configuration of these incisions on the intraop OCT microscope when you make these incisions. Anterior chamber is then filled up with the OBD, and then subsequently the ICL is injected. So as the cartridge of the ICL goes inside the wound, you can actually see that it is inside, and even the wound configuration can be seen, the configuration of the main wound as the ICL goes inside, and as it is unfolded, one can make out and actually know what is the orientation of the ICL vis-a-vis the cornea and vis-a-vis the crystalline lens. Dr. Zaldivar showed a beautiful study where he correlated post-op and intra-op OCT. And again, sometimes the pupil is so much dilated that one cannot make out whether these haptics have gone behind. And if you have this intraop OCT microscope, you can also see the iris abutting above the haptic of the ICL. And each of these is then placed inside. This is a IOCT which is of one generation older. The one which is newer can autofocus. So you can actually see the distance between the ICL and the crystalline lens. And we've devised a scale, which we've also published, how to measure the distance between the two and convert it into microns. So if you have, you can actually multiply it, measure it with the help of the scale, and notice how you can measure it with the help of the scale here, and then convert this into 7.5, multiplied by 7.5, and that is the number of microns the vault is. So again, when you do a viscoelastic aspiration, one can notice that the distance between the ICL and the crystalline lens would decrease, and the vaulting does decrease. And notice how you can make out actually that the iris strand is there and your haptic is below the iris strand. And this, although looks thicker here because the pupil has been made small for the purpose of demonstration, but you can also make out a small stump if the pupil is dilated. And this is something again which we published, correlating the ICL with the post-op vaulting. So to conclude, it is a useful tool which adds a third dimension view to the surgeons, and it helps refractive surgeons to avoid complications. It helps in intraoperative vault assessment. It is a good teaching tool for the residents and for the fellows because it helps you to see the unseen. So thank you so much for your kind attention.
All right, should we move forward? Because we are running a little late. So I'm going to invite Dr. Wiley. First, a great presentation, Dr. Sharma. Very good one. So I'm going to invite Dr. Wiley, who is going to speak to us about SMILE, pearls, and pitfalls. Dr. Wiley, I think we can't hear you.
Okay, how is that?
Okay, now it's great. Thank you.
Great, thank you. So I was saying thank you so much for including me in this great conference. It's so cool to see everybody from around the world presenting, and some great talks today and yesterday. So thank you so much, Sergio and Ashvin, for putting this together. So I'm going to talk about SMILE and integrating SMILE into your practice. And some things that come to mind, what's the best way to avoid new complications? Really, to avoid new complications is we incorporate a new technology or new technique, we're going to see new complications, and we're then have those opportunities to kind of get around those and develop new techniques to basically solve for that. So it's sort of part of the normal learning curve, and so it shouldn't steer us away from trying new things. We just should be aware of how to surpass any kind of new challenges that we see. So like I said, with any new tech, I'm just going to go through a case report that talks about a SMILE case and sort of a common mistake that early surgeons can do, including us at our clinic. So pretty routine case, 35-year-old with a mild amount of myopia. And one thing first I just wanted to lay out there is when doing SMILE, what we're doing is creating a three-dimensional lenticle with inside the cornea that we then remove. And so you have to understand there's different planes that you're working with. And so the laser goes through a series of cuts, and first starts with a lenticle cut, which is the refractive cut, which is most posterior. Then there's a side cut that comes up from that lenticle cut or refractive cut that connects to a cap cut that is a little bit wider and sort of overlaps the lenticle more anteriorly. And then the last incision is this cap opening incision. So you just have to kind of keep in mind all the different planes. And when you're first doing SMILE, it can be a little confusing to understand where you are working within the cornea. So it's good to keep that in mind when you're working through that. Here's a video showing it sped up, but that was the posterior cut followed by the anterior cut. And here we're sort of dissecting. Usually we want to dissect the first the anterior plane first, and then the posterior plane. So first we've dissected the anterior plane, and now we're looking to identify the posterior plane. And sometimes you can get a little resistance. It'd be great if we had Dr. Sharma's intraocular OCT here. That would be a great time to use this. But you can see that we're trying to identify that posterior plane. And now we believe we've had both planes identified. And now we're dissecting first the anterior plane on top of the lenticle. And now we're going to try to dissect the posterior plane behind the lenticle. And you can see here we're having a little bit of trouble finding or digging in to find that posterior plane. This is actually one of my associates' partners' cases, and he had showed me this video, and he said, you know, I just could not find that posterior plane. So you use you know, forceps to help identify and try to dissect, and you know, had a tough time demonstrating where that plane was. And he worked at it for a good 3 or 4 minutes, and ultimately just could not find that plane and decided to abort the case. He said, you know what, I just couldn't find it. So then we're sort of, you know, had to have a difficult discussion with the patient and say, you know, we just couldn't find the lenticle. It just wasn't as easy as we thought, and decided, you know, do we go on and convert this to LASIK or consider converting to PRK? And so we had some challenging discussions with the patient, and that it turns out we delayed a couple of days, and what we did was run the patient through Pentacam, and with a Pentacam we could demonstrate sort of the planes and try to identify where we were working. And you can see here the Scheinflug image shows this area of density that's actually behind the lamellar cut. So it was actually a new false passage that we're working in. You can also do a densitometry image that shows that we were deeper than the refractive cut. You can see this focal area of swelling where we're actually creating a false plane. So it turns out the whole time, when we thought we were initially in the anterior plane, it was actually already in the posterior plane, and the posterior plane was dissected. We're actually working deeper than that and creating a false channel. So with that in mind, we said, okay, well, the lenticle is there. It's just adherent to the cap and not to the bed, which we usually find. So we said, okay, we can go back after, you know, studying those Pentacam images. So here, if you go into the sulcus of the cap cut, you can slide and angle your tool anterior and slide underneath that plane, and now identify the anterior plane, which was previously not identified. So now I've got the anterior plane identified, and now we feel confident we know where the lenticle is, so we can proceed. So we slide here again, re-identify the posterior, and now I'm going to slide under. It's a little more challenging to dissect the anterior lenticle off the cap, but it can be done once you're familiar with it. And now we work to dissect the lenticle from the anterior cap and inspect it and move on. One of the key things that you look for is in that first dissection, you can look and see where the bubble pattern is, and see is the bubble pattern above or below your tool. And if it's above your tool, you know you're actually posterior rather than anterior. So you can see it in 2 spots there at the beginning, but also towards the end of the case, you can see where the tool was actually behind that bubble pattern, where the lenticle was actually in front of the tool and not behind the tool. Again, this would be with a tool like intraoperative OCT, we probably would not have had this challenge, but it's a pretty common mistake. I've had a number of surgeons I've spoken with that have gotten lost during the case and just have a difficult time identifying where those planes are. And so you always keep in mind that the lenticle could actually be adherent to the cap and not posterior. And you know, you can work your way through that with a rescue technique, as we showed, and also using other tools like Scheinflug to kind of help identify false channels can be helpful. But in summary, you know, new techniques definitely bring these new challenges. There's always new solutions to challenges that emerged and help build confidence. And thus, we shouldn't use those as barriers to kind of incorporating new techniques. We should work around those and incorporate new techniques like SMILE. Thank you.
Great presentation, Bill. As usual, you know, fantastic job. It's great to hear your experience with SMILE. I'd like to see if Dr. Benatti has a question first to start the discussion.
Yeah. Well, first of all, I want to congratulate all the speakers. Amazing talks. William, if you have to say, what is the most complication that we have when we start with SMILE for a young ophthalmologist? What would you say?
You know, I think probably working with the laser and understanding, you know, that fixation, the patient has to be calm and not move. If you can have a suction break early on, or if you don't create the planes properly. So if you have a problem during the creation of the three-dimensional shape, it can translate to trouble with dissecting and trouble removing. So I tell young surgeons that if things aren't perfect in the laser, you can always stop and abort. You can always reconsider and come back on another day, or convert to another technique, let's say PRK or LASIK. So I think as long as you don't start digging in too much and creating damage, you can always, what's nice about SMILE is you can always stop, reevaluate, consider either going back in or consider converting to another technique.
I loved your message. New surgical procedures, new complications. That's great, right? And I think we have to think about it.
Thank you.
I saw there was a number of questions for Roger in the question area, but I'll just vocalize two of them. This for Roger and the ICL. The first question was, here in the US, we don't have the EVO. Can you rotate the lens 90 degrees, or will that put patients at risk for a blockage for angle closure?
That's a great question, and I was about to answer it in the Q&A. It's not ideal. It's not ideal to place the ICL vertical if you're going to have of course the iriectomy in the 12th degree meridian. But what you can do is you can put it oblique. Oblique is an alternative. We have seen an intermediate decrease in bolting, put it oblique. And by the way, it's one of our approaches. Whenever we want to decrease a little bit the bolt, we just put it oblique. And if we want to be more aggressive, we just put it vertical. So in this case, at least you will have a soft approach.
Beautiful. Were there any other questions from the other speakers or from Marcony for Dr. Zaldivar?
Yeah, I just have a quick question for Roger. Roger, how's your experience with toric fake IOL for irregular corneas with keratoconus? And question number one. Number two, real quick, is you have an experience combining toric fake IOL and cross-linking for keratoconus? And
yes,
how does this work?
Yes, we have been doing this for many years, and of course, it's something acceptable if it's a benefit for the patient. So whenever you see that the manifest refraction, it's improving in a considerable way the best refractive outcome. So then we consider doing a Phakic, toric. And after cross-linking and rings, we do it in a standard base. No, nothing different than that.
I had a question for Dr. Roger. You said that you correlated the intra-op OCT findings with the post-op OCT findings. So what correlation did you find in that? I mean, because they do change. The vault which is there intraoperatively is a little different from the vault that you see on post-op day 1 or post-op week 1.
It's very close. It's only a difference about 100 microns. So it's very acceptable in order to take a quick decision whenever you see that there is a risk of angle closure, you just decrease it. And the worst that can happen is that you have a variability of 100 microns, 120. So it's always positive to avoid that risk.
We had two questions asking about the iris clip or iris claw phakic IOL. Anyone have any experience? I don't know, Roger, do you have experience? Is it an equal technology or?
You know, my father had a huge experience here, but the reality is that we've been doing iris claw at the beginning, and see, it's a good alternative for some patients. They have some positives. One of the positives is that sizing is not that important. It's one size fits all. Another interesting approach is that it can correct more myopia because there is a higher range. ICL, the highest is 18 diopters. So whenever you have more than that and you cannot correct more in the cornea, like bioptics, you can jump to a iris claw. But still, I think that the ICL today with the central flow and with the benefits that you have and how easy it is to do it and to take it out whenever you have to do a phaco in the future, that you can take it out through a small incision, for me it's a no-brainer. But of course it's a matter of each experience.
I have a question to Dr. Sharma and to Wiley. But first, Dr. Sharma, how often you change your approach based on the intraoperative OCT? I mean, so you had your approach in your mind, and then you had to change in terms of percentage. Just putting in that market in perspective, considering how many people or surgeons should have the intraoperative OCT. How many in percentage procedure would you change based on the intraoperative OCT?
So the microscope, the company for the IOCT and for the SMILE is the same. And that's what we were even advising Zeiss, why can't you integrate the two together, because SMILE procedures will become a lot easier. Now this thing came up intraop OCT microscope because we had a case where the retained lenticule was there, and then we did anterior segment OCT, and then we got the patient just pretty much like Dr. William. We took the patient again on another day, which was a little distressing to tell the patient that, you know, you've not done it completely and you have to do it another day. So when it happened the second time, when that whole lenticule got stuck to the back of the cornea, then we immediately, it just occurred to us that we do have intraop OCT microscope in our hospital, and we have many of them, in fact, almost 7 of them in number. And that's when it struck that rather than postponing the surgery for another day, why don't we take this patient to another OR and look at the picture of the lenticule in the IOCT, and that's how, you know, it occurred that this would be a useful tool. And it'll be good if the companies integrate this intraop OCT microscope in the SMILE. Having said this, I don't say that, you know, it is an investment that you must do just for doing this, because there's so many SMILE surgeons, in fact, almost all of them who are doing without it and doing a great job. But then if you do have it, then it's a good tool. And maybe in future, these two things can be integrated.
Yeah, well, I fully agree with you. It was a great presentation. And Bill Wiley, would you have any pearl for people that have epithelial ingrowth after SMILE? How would you handle that? I mean, this is one question I get all the time from people that are not using SMILE, and somehow, you know, they just, you know, find a patient that come complaining about that. How would you handle that? To me, it's one of the, you know, most horrible situations with this.
With epithelial ingrowth?
Yeah.
Yeah, so, you know, I thankfully I've seen that as a very rare situation, but I have seen it where inadvertently a nest of epithelial cells is implanted into the pocket, and let's say inferior or far from the incision, because with LASIK you can lift the flap and remove, and it's pretty easy. With SMILE, you have to go into the pocket and remove that epithelial cell. So thankfully, you know, the cases I've seen have been rare, and they've washed out, you know, rather well, and I have not seen reoccurrence. I've been prepared if for some reason I did get reoccurrence in that, to use YAG laser to stop the proliferation of the epithelial cells. But thankfully, you know, epithelial ingrowth with SMILE is pretty rare. You know, I see it more commonly with LASIK, particularly, let's say, LASIK enhancements and things like that. So I feel like it's one of the advantages of SMILE. It's rare, but I suppose when it does occur, it presents its own challenge because you don't have that flap edge to lift and slide underneath.
Beautiful.
Great.
No, thank you. Yeah. I think we're near the end. We're just going to ask all the panelists and all the speakers to give a final comment or so. We have about 2 minutes left. So I guess we could start with Wolfgang to give a final thought, and then we'll go down to all the speakers and have Andres, and then the moderators will make the last remarks.
Yeah, just what I said before, I think we have amazing technology available right now, and working together and get this to the next level. I think this will be the key for our generation. I still consider you as well, the younger generation, Bill. And I think, yeah, to work all globally together, I think this is just an amazing tool, the webinars, the education, and thanks to everyone.
Roger?
Just supporting my friend, I think that Phakic IOLs and more the ICL today is an incredible approach to fix these high myopes and patients with dry eye or different conditions. And I think that the future is going to be very, very bright. Today we have a very good alternative to use, and it's all about focusing in trying to be more predictable with this, and this will be a standard procedure that we'll be able to use it in many, many patients.
Thank you. Namrata?
So I think we have to go to another level now in refractive surgery, whether it was Dr. Wolfgang who, talked about his talk, and he said that, we can go up to say -10 diopters, or whether it was SMILE, which is now also coming. In the newer companies are working on the fact that you don't have to dissect the lenticule and you can just, make a lenticule and pull it out, or whether it is the integration of intraop OCT microscope with the SMILE procedure or intraop OCT microscope for the refractive IOLs. I think it's going to be a different platform in the years to come as far as refractive surgery is concerned.
Gabriel?
Sure. I think, I'd like to echo everybody's talks. I think we're seeing better efficacy and better safety and more procedures to basically capture almost any refractive surgery patient. When I first started, all we had was LASIK and PRK, and we tried to put everybody into those two procedures. And we had some patients that didn't do quite so well. Now I think there's the right procedure for the right patient. I think sharing ideas amongst worldwide colleagues is amazing. I've learned so much today, and the speed at which we can share our pearls and techniques and technologies, I think it's only going to help our field. So it's super exciting to be involved with this. So thank you.
And great, and before I hand back, Bill, before I hand back to you and to Sergio and Ashwin, I just want to have a quick invitation, real quick. So let me share my screen here. All right, guys. So can you guys see me there?
Yes.
You can, right? So I'd like to invite you all for the course that we organize in Rio. It's called Refractive Rio. It's going to be through March 17th to 21st of 2021. Lots of friends here will be in the panel and in the discussion and presenting. If not all of you will be here, as the speakers. It's going to be, 60 hours, 5 days course. So it's a very deep course with everything you need to know about refractive surgery, more than 50 international speakers. And we are going to have more than 100 classes. And there are 25 highly elaborated wet labs, so it's very hands-on. I mean, all the wet labs have specific guidelines, specific professors. We put a lot of time on that. So the whole course is translated into English and Spanish and obviously Portuguese. So you just need to pick up your headphone and you are all set. So these are some pictures of the wet labs we have: SMILE, Phakic, IOL. We divided the wet labs in 3 groups: planning, technology, and surgery. So these are some videos. Like I said, all kinds of technology we have. This is one of our discussions. We have people from hopefully the world will be back to normal, and you'll be able to see each other and interact again next year. So if you want any more information, just go to the website cursorefractivario.com. And again, all my friends will be here: Ashwin, Sergio, Bill, all the Bills here, Benatti, Roger, Sharma, everyone. So I hope you guys are able to come. Invitations coming soon. And if you have any doubts, please just email me or just reach out to me through the Instagram account. It's Marcony with Y, Santhiago with TH. I'm gonna hand back to Bill Trattler to finish this. And again, thank you very much, Sergio and Ashwin, for putting together this great meeting. And thank you very much, Bill Trattler, for sharing this with me and all the panelists and all the speakers. Great job you guys did. And also Benatti, thank you very much.
Yes,
thank you, guys.
Marcony.
Thank you
for the invitation.
Any last thoughts, Andres?
Yeah, I think we are facing a new era in refractive surgery, and the key word of this new era is the customization. In the future, we will find a specific procedure for every patient. So welcome for that. Thank you so much, the organizer, moderators, the speakers, of course, especially Roger, the Argentinian. We don't have a virtual background, but we have Roger and his father, and we have learned a lot from them. So thank you, guys.
That's a background, right?
Yeah, that is. So on my end, I can't thank the speakers, incredible talks, Andres for being a great panelist. Marcony is just a rising rock star in the world of refractive surgery. And this course you're putting on looks really exciting in March. I'm hoping that we'll all be traveling. I think every one of the speakers and panelists, and I know Marcony and myself, can't thank Sergio and Ashwin enough for developing this incredible forum for us to learn from each other and share our thoughts with the world. So Ashwin, Sergio, you guys are rock stars. Thank you so much for having us. Thank you.
You guys, thank you very much.
Thank you, guys.
Thank you.
Thank you, guys. Thank you. Amazing session.